Thanks to all of our folks who are with us today. I'm just so excited to be with you to talk about the thyroid. I feel like when I went through my medical training 25 years ago, I didn't appreciate how common thyroid disorders are. And I'll share with you some stories that really got me to step up and do more thyroid care in my practice. And hopefully I'll motivate you to either do more of what you're doing already or to help to deal with this tremendous unmet need. So we're going to talk about thyroid disorders, integrative assessment and treatment. The focus is primarily going to be on hypothyroidism, which is the main thing that I deal with in my practice, although I have a few slides on hyperthyroidism as well. So let me start first with an overview. We're going to talk about the epidemiology of thyroid disorders. And if you've heard any of my other talks, you know that I have a bias towards systems biology. And so I think it's really important to understand where the thyroid fits into the larger endocrine system, as well as what I think of as the control system for hormones in the body, which I like to label as the hypothalamic pituitary adrenal thyroid gonadal gut axis. That's quite a mouthful, so I'll be talking about the HPA, TGG as the short version. We're going to talk about systems as well as diagnosis, nutrient signaling, how I assess for nutrient signaling, and hopefully you guys may have some questions about that, and then we'll talk about treatment. So let's go first to the epidemiology. I like to look at lifetime risk. I think that's a very helpful way to look at different conditions that our patients face. And we know in the US population that about 12% will develop a thyroid condition. And that's all comers. So if you then break it down into lifetime risk of different types of thyroid disorders, 4 to 10% develop hypothyroidism, about 10% subclinical hypothyroidism. We'll discuss what that is, as well as some of the controversies in managing subclinical hypothyroidism. And then a much smaller percentage, somewhere around 2 to 3%, develop hyperthyroidism. Here's the part that I think should get us all into action. 60 to 70% of people with thyroid disease are unaware of their condition. And this is one of those things that makes me slightly crazy, because what I find routinely in my practice, I take care of mostly women. I have a few men in my practice as well. But what I find is that many of my patients who've been talking to their, well-meaning primary care doctor about their symptoms of often hypothyroidism, they often get dismissed. Occasionally they'll get a TSH, but often they don't get more than that. In fact, I'll tell you a quick story about what first got me motivated to learn more about thyroid dysregulation and dysfunction. When I finished residency in 1998, I went to work at a large health maintenance organization. And I was trying to be careful about stepping on other people's toes, but I had a patient who came to see me for a pap smear who had classic symptoms of hypothyroidism, and we'll get into the details of those. But she had constipation, she had cold intolerance, she had some hair loss, she had some weight gain, she had fatigue that was all day long, which in my mind is one of those cardinal signs of hypothyroidism, more so than some of the other energy patterns that we can see with adrenal dysregulation, with HPA dysregulation. And so I checked her TSH, and her TSH was 4.2, and she had a low free T4. And so I thought she should be treated. I called her primary care doctor to discuss it, and he absolutely refused to offer her treatment. He said, here at the HMO, we don't treat TSH until it's greater than 5, and in some cases, we don't treat until it's greater than 10. depending on other circumstances. And I just thought that was wrong. And so I wrote her a prescription for, at that time, levothyroxine. I've since changed the way that I approach patients with hypothyroidism. We'll get into that detail. But it just made me realize, okay, there are so many patients, especially women, who are not getting adequately screened and treated for their symptoms of hypothyroidism. So we know that hypothyroidism is the second most common endocrine disorder affecting women of reproductive age. The number one, of course, being polycystic ovarian syndrome, and that's present in 10 to 30% of patients, depending on the criteria that you use. We also know that the most common cause of hypothyroidism in terms of mechanism is Hashimoto's thyroiditis, also known as autoimmune thyroiditis. And this is 5 to 10 times more common in women. The latest data are showing about a 7x increased risk. We know that the prevalence of Hashimoto's thyroiditis is about 5% of the US population, and that's based on the latest data, 2017 to present. That makes it the most common autoimmune disorder that patients face. The most common cause of hyperthyroidism is Graves' disease. And as I mentioned, we'll talk a bit about Graves'. So let's talk about Hashimoto's thyroiditis. You know, I prefer the term autoimmune thyroiditis, but I tend to use Hashimoto's just because so many of my patients use it. You know, they call it Hashis for short. And so I've gotten in the habit of using it, and I'll switch in and out of it as we go along. So let's talk a little bit about the sequence with Hashimoto's thyroiditis. It was described over 100 years ago, and the classic description is that it's a lymphoid goiter. But there's other clinico-pathological entities that fit under this autoimmune category as well, including the fibrous variant, the IgG4 related variant, the juvenile form, Hashimotoxicosis, and also painless thyroiditis, which you can see sporadically or postpartum. We know that the pathological feature of Hashimoto's is lymphocytic infiltration, especially of T cells. And then what follows is follicular destruction. These are the histological hallmarks of autoimmune thyroiditis that lead to gradual atrophy and fibrosis. And as someone who takes care of a fair number of patients with Hashimoto's, and perhaps you do as well, what we know is that there tend to be flares, there tend to be triggers that can precede a flare, and patients tend to have this period sometimes of increased overfunction when they're getting overstimulated by the immune system, followed by a decline in function. So we know that in terms of the pathogenesis of autoimmune thyroid disorders, AITDs, is due to chemokines and cytokines. And we know that in about 20% of patients with autoimmune thyroid disorders, they have other organ-specific systemic autoimmune disorders. We also know there was a lot of controversy about whether Hashimoto's or autoimmune thyroiditis puts you at a greater risk of thyroid cancer. And this has been shown quite definitively in the past few years to be an important association. In fact, I would even say it's more than just the papillary thyroid cancer, it's other types of thyroid cancer as well. In fact, right before I got on the phone, I just was looking up a citation on this. Here's a little on-the-fly literature search. So this is a study of 64,000 patients published by Cristina Rezende de Paiva. And what they found was that there was an association. Well, this showed the papillary thyroid cancer. I was mistaken. It's mostly papillary that's been shown, as well as one other type, thyroid lymphoma. So this was published in, well, we can make this available to you. On my phone, I can't see the year. I think it was 2017. So a quick comment about thyroid cancer. I'm sure that your practice has been affected by the rise in thyroid cancer. We know that it's been increasing in prevalence about 5% per year. So this is really alarming to a lot of patients, especially women. And I think understanding this link between the immune system, how it's associated with loss of tolerance and autoimmune destruction, and then a greater risk of cancer, understanding that mechanism, that sequence, that flow is really important for us going forward. So let's talk about the systems biology of the thyroid, where it fits in. So I took one segment of the hypothalamic pituitary thyroid gonadal adrenal gut axis, and I'm just showing here the hypothalamic pituitary thyroid axis, HPT. What we know is that TRH is made in the hypothalamus. This then travels to the pituitary in the brain. This leads to release of TSH. And then the TSH travels in the bloodstream to the thyroid gland, where it stimulates production of T4, which can then be converted into either T3 or reverse T3. So these are important because, as you'll see when we get into the issues related to diagnosis, what I find in a lot of my patients is that this conversion from T4 to T3 is problematic. So they don't convert well for a variety of reasons. That can be genetic, it can be related to high estrogens, it can be related to cortisol levels, either high or low. It could also be related to dysbiosis, including SIBO. And what I find in many of my patients, once I started looking for it, and this was about 15 years ago, is that sometimes they make too much reverse T3. And this is one of those regulatory hormones that can bind to the T3 receptor throughout the body and effectively block the action of free T3. So let me just back up a little bit and mention, I think you probably remember this from your medical training. I think of T4 as the main storage hormones. We have this pool of T4 that's made as a result of TSH stimulation. And then we have this pool of T3. And a large portion of T4 and T3 are bound to thyroid globulin. What we know is that the free levels are what are biologically active. And so that's what I tend to measure in my patients when I do a thyroid panel. As I'll share with you in a moment, I'm looking at TSH, free T4, free T3, and reverse T3. I also tend to check antibodies on all of my patients, as we'll get into later, because it's so common for them to have autoimmune thyroiditis. And the treatment is different if they have an autoimmune condition. So this brings us to thyroid disease and some of the sex and gender differences. We know that the prevalence of thyroid disease is much higher in females, and it increases with age. I have a friend who likes to talk about thyropause. So you've heard of perimenopause, you've heard of menopause, certainly. Thyropause is when your thyroid ceases to function normally, or you're on kind of this diminished path with thyroid function. And we know that this tends to occur in women between the ages of about 40 and 60. The most common abnormality that's found is subclinical hypothyroidism. And this occurs in 20% of postmenopausal women. So women have higher rates of thyroid autoimmunity, and that's not just Hashimoto's, but also Graves' disease, rheumatoid arthritis, if we look more broadly at other autoimmune conditions. We know that for people who are at risk of thyroid disease, such as adult women, they may have less ability to compensate for the additional challenges to thyroid metabolism, and that includes lithium treatment, which may be relevant in your practice. We also know that thyroid abnormalities are associated with a poorer response to standard treatments for mood disorders. So this is probably relevant in your practice of the care of patients with mental health and maybe psychiatry. We know that women with treatment-resistant mood disorders have responded better than men to adjunctive therapy with thyroid hormones, especially T3. So what can we conclude from this? We can conclude that disturbances of thyroid system function, which occur very commonly in women, tend to complicate the diagnosis and treatment of mood disorders. And this is especially relevant during lithium treatment because lithium can impair the thyroid metabolic pathways secondary to its anti-thyroid activity. So let's talk about the signs and symptoms of hypothyroidism. What I do is I use a questionnaire in my practice. And so before a patient comes to see me, I'm looking at their perceived stress. I think that's one of the best scales developed by Sheldon Cohen to assess cortisol levels. It's a really simple questionnaire that you can get online. And that's one of the questionnaires that I have my patients see before they come in to see me for the first visit. I also have them fill out a questionnaire for not just thyroid, but for other hormones such as estrogen, progesterone, testosterone. And if they have weight issues, I'm going to be looking at insulin, leptin, et cetera. So let's go through some of these symptoms, most of which I'm sure you're aware of already. Generally, fatigue, feeling cold hands, cold feet, weight gain with poor appetite. These are very common with hypothyroidism. Hair loss. The classic with hair loss is the outer third of the eyebrow, but I also see in these patients that they have loss of eyelashes and potentially loss of head hair. In terms of lung function, there can be shortness of breath and pleural effusion with more serious hypothyroidism. There's some skin changes. Constipation is definitely common. And what I tend to see with my patients who are hypothyroid is that they have long-standing constipation. The way that I define constipation is a little bit different than allopathic medicine. In allopathic medicine, we're fine with patients pooping once every 3 days. I don't think that's sufficient for detoxification. I prefer for my patients to be pooping once or twice a day and to feel like they're evacuating completely. And so in hypothyroidism, what I commonly see is that patients have decreased emptying. And so their motility is decreased in terms of their intestinal function. And this puts them at greater risk of dysbiosis and small intestinal bacterial overgrowth. Menstrual function can also be affected. So in terms of the reproductive system, you can see heavier menstrual bleeding, menorrhagia. And on the other hand, with hyperthyroidism, you can see the opposite. What about psychological issues? Definitely poor memory and concentration, poor hearing. Another thing I see very commonly is brain fog. I think about the thyroid with brain fog, and I also think in terms of barrier function. So both the gut lining as well as the blood-brain barrier. With the pharynx, there's hoarseness. You can hear some hoarseness in my voice. I have hypothyroidism, and since I was diagnosed, I've had hoarseness. With the heart, you can see a slow pulse rate. You can also see a pericardial effusion. Muscular, you can see delayed reflex relaxation. So testing your patients for the reflexes can be helpful. And then in terms of extremities, we mentioned coldness and carpal tunnel syndrome. And I think I'll tell you one quick story here that hopefully will make this come alive. When I had my second baby at age 38, I was still working at the same health maintenance organization. And I don't know about my thyroid function during that time because we weren't doing routine TSHs and free T4s in patients. That daughter is now 15. But I had a number of these symptoms of hypothyroidism. So I had decreased energy for sure. I had some mood issues heading toward depression, not major depression, but depressive symptoms. I had constipation. I had hair loss. But the problem was when I was postpartum was that many of these were considered by my OBGYN to be a result of just having given birth to a baby. So the mood issues, the hair loss, just feeling fatigued all the time. All of that was kind of written off as being, oh, well, you're postpartum, you're breastfeeding, you're not sleeping well. Write it out. Just try to, carry on. And so I was pretty frustrated with being told that by my OBGYN. So I left her office and I went and measured my TSH, which was elevated at about above 3. And my free T3 was very low. And so I realized that I had hypothyroidism. And that's what helped me see, beyond the patients I was seeing in my practice, helped me see that in allopathic medicine, I wasn't sufficiently taught to be screening patients for this. So my little plug here is to be thinking about hypothyroidism in the back of your mind, especially in patients who are postpartum, because it's very common for them to have thyroid dysfunction. So what are some of the signs? We mentioned several of them already. With hypothyroidism, hair loss is common. We know that most people lose about 50 to 100 hairs per day. When you have a lot more than that, when you find that your ponytail, instead of wrapping your band around your ponytail twice, you now have to wrap it around 3 or 4 times, that is a signal that there's significant hair loss. There's periorbital edema. There's the outer eyebrow thinning. You can see a scalloped tongue in more severe cases, a goiter. I do a thyroid exam on all of my patients. Thin, brittle nails, plumber's nails. And I see I have periorbital edema twice here. So I think watching for these signs is very important. And then we want to put it together with thyroid testing. So what about hyperthyroidism? Let's just talk about some of those symptoms. Hair loss is a symptom as well of both hypothyroidism and hyperthyroidism. Bulging eyes are common, increased sweating, enlarged thyroid, rapid heartbeat, nervousness, heat intolerance, scant menstrual periods, so the opposite of menorrhagia, warm, moist palms, difficulty sleeping, tremor of fingers, irritability, infertility, muscle weakness, weight loss, frequent bowel movements, and soft nails. Another thing that I see pretty commonly is palpitations. So with the systems biology framework, which I think is really important to integrative care, or I've changed the way that I describe my practice over the years. I started out calling myself an integrative gynecologist. Then I shifted to using more functional medicine. I went through a functional medicine phase, and now I practice more precision and personalized medicine. But in many ways, the underlying concepts are the same. And that's using a systems-based integrative approach to the way that we think about something like hypothyroidism. So when it comes to the thyroid, here's some of those systems that we want to be thinking of. So in the center of this infographic, we have the thyroid producing T4, which then produces either free T3 by removing an iodine or reverse T3. And this goes on to stimulate the thyroid receptor inside the cell, the nuclear receptor. So let's talk about some of the factors that can affect the production of T4. That includes having decreased iron, decreased iodine or excess iodine, tyrosine, zinc, selenium, and vitamins E, B2, B3, B6, C, and D. So all of these nutrients are involved in the production of T4 as well as the conversion later to either T3 or reverse T3. And I want to take on iron for just a moment, because what I find is that so many of my patients are low in iron. And I think this was another factor for me when I was postpartum. So I had a really low ferritin. I've kind of always had a really low ferritin in the range of like 10 to 20. 20 is when I'm really on my game and getting the iron that I need. But we know if you have low iron, it's another factor that's involved in the production of T4 and its downstream activity. When you think about the structure of T4 and T3, T4 is basically a tyrosine base with 4-iodine attached to it. And what happens in terms of the conversion from T4 to T3 is that you're removing one of the iodines. So for patients that are low in tyrosine or low in some of these other nutrient factors, they may have difficulty with the production of T4 and then downstream consequences. So what are some of the factors that are involved in the production of T3, reverse T3? With reverse T3, we think about stress, trauma, a low-carb diet. So I have a lot of patients who are on a ketogenic diet. You can ask questions about that, but one of the common issues in patients on a ketogenic diet is that they may have increased reverse T3. And so that's one thing you can check. I have sort of a keto panel that I run on my keto refugees when I try to get them onto a better formulated plan. We can still work with ketosis depending on what their goals are, but sometimes you need to add back, especially prebiotic carbohydrates, and sort of see what their carbohydrate tolerance is as a way of helping with their thyroid function. Inflammation can do this. Toxins, the toxins that I think about the most and that I see the most in my patients who have high reverse T3 are bromide and fluoride. So I ask them, okay, what toothbrush are you using? What mouthwash are you using? Does it contain fluoride? What do you know about your water supply? Do you use filtered water? Also, liver and kidney dysfunction can affect the conversion of T4 to reverse T3 and certain medications. So we know that about 80% of the conversion from T4 to T3 occurs in the liver, and slightly less than 20% occurs in the gut. And I believe some occurs in the brain as well. I don't know the percentage. So some other factors that inhibit the production of thyroid hormones: stress, infection, trauma, radiation, certain medications, flour, other toxins like pesticides, lead, mercury, cadmium, autoimmunity, and celiac disease. And then what I would add in terms of the conversion from T4 to T3 is the issues of zinc, selenium. I would add copper here, as well as the cell's sensitivity to thyroid hormone, and that includes vitamin A, exercise, and zinc. Now, we've had a lot of interest in zinc recently, you may have noticed, and I think it's important when we're looking at zinc to think about how it functions in the body. And so I would say it's not just a problem with deficient zinc, it can also be that the copper-zinc ratio is out of balance. So let's talk about the brain. We're going to talk about DIO2. And this is something that I started to pay a lot more attention to. I'll just tell you that I learned about this from Todd Lepine. He's someone that I really respect a lot, an internist who practices functional and integrative medicine. And once he got my attention by sending some of these papers that are listed here on how the body converts T4 to T3, how it deiodinates, it made me realize that there's some reasons why some of our patients may need additional thyroid hormone in order to function at an optimal level. So the type 2 DIO2 is the one that I pay a lot of attention to. And this is the one that's associated with the lower conversion from T4 to T3, especially in the brain. So I have two variants that are listed here. They're considered to have a moderate impact on the brain's ability to respond to circulating T4 levels. So what I realized, what happened in my case was that I did not have autoimmune thyroiditis. I had more of a functional decrease in free T3 and an elevation in TSH as a result of it. And so when I made some micronutrient changes, I actually found that my thyroid functioned a lot better. And I'll get into those details in a moment. So I started to increase my vitamin D, my zinc, copper. I started to manage my cortisol better and worked on my estrogen dominance. And all of these things, the net result was that my thyroid functioned better. But Todd actually said, why don't you check and see if you have these SNPs? Because if you have one of these, you actually may want to continue thyroid hormone medication. And in fact, I did. So there's a few other genes that are listed here, but it's really the DIO2 that you want to pay the most attention to. And the important point here is a quote from Geneben, which is, the activating D2 and the inactivating D3 can locally increase or decrease thyroid hormone signaling in a tissue and temporal specific fashion, independent of changes in thyroid hormone serum concentrations. So this is a functional effect that may or may not be reflected in laboratory testing. So what about cardiometabolic changes in hypothyroidism? I've been paying a lot of attention to cardiovascular disease recently, so I added these slides because I believe that hypothyroidism maps to a greater risk of cardiovascular disease, in part due to its lipid effect, but also due to other mechanical effects that are listed here. So on the left, with hypothyroidism, you can have this pathway that leads to increased diastolic blood pressure, increased afterload, decreased cardiac contractility, and decreased cardiac output. And we know, for instance, that women are at risk of having increased diastolic dysfunction. So this is something I think about a lot in terms of weighing the risk, benefits, and alternatives of treating patients with hypothyroidism with medication. Some of the molecular mechanisms that underlie this, of course, are listed here as well, and that includes endothelial dysfunction, decreased nitric oxide production, decreased vascular smooth muscle relaxation, which is what can be associated with diastolic dysfunction, and then, of course, decreased cardiac contractility. So what about the lipid effect? So we know that there's an increase in total cholesterol, there's an increase in LDL, there's an increase in apolipoprotein B. Patients with hypothyroidism also can have an increase in C-reactive protein and an increase in homocysteine. The molecular mechanisms that underlie these include a decrease in the number of LDL receptors, a decrease in LDL clearance. So let's start talking about some of the thyroid function tests. This is where there's been, I would say, some significant changes. Not that recently, more like 15 years ago, 15 to 17 years ago, and I just want to share these with you. So I told you when I was first in practice in 1998, at that time, this range here of a TSH of greater than 5 or even 10 was the norm at the health maintenance organization where I worked. And so that was the way that you would diagnose overt hypothyroidism when it was associated with a low free T4. The HMO that I worked at did not run T3s. You had to have an endocrinologist order them. But I think it's important to realize here that the range of a TSH greater than 4.5 or 5 or even 10 is outdated. And maybe you're similarly old enough that you've seen how difficult it is to get US clinicians to turn the corner when it comes to new guidelines. And so I want to share with you the ranges that I use. So in 2002, the American Association for Clinical Chemistry issued new guidelines where they said that the upper limit of normal TSH should be 2.5 milli international units per liter, 2.5. So that's what I've used here. So as you can see with subclinical hypothyroidism, the definition is a TSH greater than 2.5 with a low or low normal free T3 and free T4. Normal is considered 0.3 to 2.5 with a normal free T3 and free T4. Now, in 2003, the American Association of Clinical Endocrinologists changed their recommended target in response to the American Association for Clinical Chemistry to 0.3 to 3.0. So not quite the same as the American Association for Clinical Chemistry, but at least it was a step in the right direction for a relatively conservative organization like the American Association of Clinical Endocrinologists. Now, another point here that I think is important is that if you look at the literature, if you look at people, the problem here is that when you look at the general population, which is what these organizations did, I told you earlier that 60 to 70% of the population that has hypothyroidism doesn't know it. And so when you look at the bell-shaped curve of the normal population, many of those folks actually have hypothyroidism. Some of them have hyperthyroidism, but a much greater proportion has hypothyroidism. And so if you just take people who have completely normal thyroid function, they are euthyroid, we could make an argument that you want an even tighter range with TSH. And I wrote about this in my first book, The Hormone Cure. This is page 242, where I cited Wartofsky from 2005, who said that he could make a strong argument based on the literature for an upper limit of 1.5 milli-international units per liter. So what range do I use? It's the range that's shown here, where normal is 0.3 to 2.5, and low TSH is less than 0.3. This is hyperthyroidism, and it can be associated with a high free T3 and or free T4. Some people who practice integrative, I would say more anti-aging medicine, might even use a lower threshold of 0.1. I've found in my practice that 0.3 is really the range that works the best for me. So we know that 99% of T4 is bound to thyroxine binding globulin. So I've got the range here for free T4 and free T3, reverse T3, TPO, and anti-thyroglobulin. And I think the important thing here, what I do in my practice is when I'm treating a patient, I want the TSH to be less than 2.5 and to be pretty consistent. I also want the free T4 and the free T3 to be in the top half of the normal range. And I want the reverse T3 to be in the bottom half of the normal range. So for instance, with free T3, and this depends on your local lab, you have to look at the range for your local lab, but this is my local lab. So if you just run the math here with free T3, 2.8 to 4.4, let's see if I can do the math on the fly. So that's a 1.6 span. And if you add 0.8 to 2.8, that's basically 3.6 to 4.4, where I want my patients to be. And then with reverse T3, that's a span of 14. So I want the range to be 10 to 17 nanograms per deciliter. So that's a little thyroid math. I hope that is helpful for you. One other factor to consider is the ratio of free T3 to reverse T3. And I wonder if any of you use this ratio in your practice. If you do, I'd like to hear from you. I'd like to hear what sort of range you like to use. What I tend to use is I want the free T3 divided by the reverse T3 to be greater than 0.2. Okay, so hopefully that makes sense. So let's talk about overt and subclinical hypothyroidism. I have mixed feelings about this, but let's just take this on. So even conventional obstetrician gynecologists believe that subclinical hypothyroidism can lead to a greater risk of infertility, miscarriage, and adverse obstetrical and neurodevelopment outcomes. And so the way that OBGYNs define subclinical hypothyroidism is a TSH that's greater than 4 with normal free T4 levels. Now, the upper limit of normal in most labs is 4 for non-pregnant women and 2.5 for the first trimester of pregnancy. So you have to realize that in pregnancy, the range that you want is actually tighter. So it's controversial whether to use first trimester pregnancy thresholds for the upper limit of TSH to diagnose and treat subclinical hypothyroidism in women attempting pregnancy, but I do. So the guidelines that I tend to follow is I want the TSH to be between 0.3 and 2.5 in my patients who are trying to conceive or who are pregnant. And for patients who are on medication, who are trying to conceive or who are pregnant, I try to keep their TSH between 0.3 and 2.0. So that's what I was taught to do as I went through my medical training. It was a more aggressive approach to a narrow TSH range, and that's what I still use with these patients. So I think the important piece to take away here is that we can all agree that testing TSH, doing a thyroid panel in infertile women attempting pregnancy is important. This idea that, there's consensus that TSH slightly lower of greater than 4 should be treated with levothyroxine to maintain levels below 2.5. As I mentioned, my personal approach is a little more aggressive and has a more narrow range. And this point about, keeping a patient therapeutic who's being treated medically with a TSH between 0.3 and 2.5. So let's talk about some of these key nutrients. So with thyroid function, I just want to pull out some of these important points. We know sufficient protein is important because the backbone of T4 and T3, as I mentioned, is tyrosine. So you need to have adequate amino acids to help patients be able to produce T4 and T3, and not getting adequate protein can be a problem. You want sufficient iron. The most sensitive indicator of that, as you know, is ferritin. And for patients who are experiencing hair loss, what we know is that ideally, you want a ferritin that is above 40. So I like to get my patients who have low ferritin between 40 and 70 if they're having hair loss. We know in terms of increasing new hair, so not just stabilizing hair loss, but actually making new hair, you need to have a ferritin level of about 70 to 80. You want to have adequate selenium. There's a lot of controversy about iodine because there's some fear that giving iodine as a supplement could actually cause Hashimoto's flare. And what I found in my patients is that I like to test them for iodine. I find among my hypothyroid patients that a large number of them are deficient or low in iodine levels. So I like to do urine spot iodine tests. Again, there's some controversy here, but in terms of treating, what I tend to do is I start with a food first philosophy with all of these nutrients, especially iodine. And so I encourage my patients to eat sea vegetables as a source of iodine. And I do sometimes use iodine supplements in my patients that are low in iodine. And I find that if they're replete in selenium, they do not have problems on iodine. They don't have problems with autoimmune flares. Vitamin A is also important, zinc, as I mentioned, and L-tyrosine, which you can take as a separate supplement. As we talked about at the beginning, there's this, for the control system, the HPA TGG, hypothalamic pituitary adrenal thyroid gonadal axis, gonadal gut axis, we know that adrenal function is really important to thyroid function. And as you know, when it comes to adrenal function, you want to make sure that your patients are getting adequate B vitamins, especially B5, B6, vitamin E, magnesium, Celtic sea salt, vitamin C, and trace minerals. And one of the things that I was always taught in functional medicine, and I believe they still teach us today, is that when you look at a patient who's got thyroid dysregulation, they tend to have more problems in the HPA TGG. And so you want to be addressing all of these concerns, because if you only treat the thyroid, you may not get long-term success. In fact, chances are you won't. And one of the things that I do with my patients when I diagnose them with hypothyroidism is I will address their cortisol issues first. The way that I like to measure cortisol function is with the dried urine test, and you can ask questions about that if you don't use it, or comment if you have another way that you like to look at cortisol, such as adrenal stress index or saliva testing or even serum testing. And what I do is I start to work on adrenal function alongside addressing their thyroid function. Because what I found when I first started treating patients 15 years ago, as I mentioned, my daughter's 15 years old. This is when I first started to treat more patients using an integrative paradigm. What I found was that if I just started these patients on thyroid medication, and we'll get into the details in just a moment, if I just started them on, say, at that time, Nature Thyroid or Armor Thyroid, often what would happen would be that they would feel better for a short period of time and then they'd crash again. And so when I layered in this cortisol unlock, when I started to address their HPA and then treated alongside their thyroid function, I got much better results. And the same is true in terms of gut function, patients who have dysestrogenism. You can ask more about that if you'd like. So let's talk about treatment, and then I'm going to take some of your questions. Will wanted to make sure that I talk about sort of how I approach treatment. And I can tell you, for patients who come to see me and they're already on T4, they're taking levothyroxine, they're taking Synthroid, what I often do in that situation is just, if they're happy with it, if they don't have hair loss, which can actually be a side effect of Synthroid, if they're happy with it, I'll look at how their T3, their free T3 and their reverse T3 is functioning. And often in those patients, I'll end up adding a little T3. Typically, I'll use Cytomel, but not everyone can tolerate that. And occasionally, I'll have to compound it. Sometimes in those patients who are already on T4 and they're happy with it, I'll actually add a small dose of Nature Thyroid, just like a quarter grain. And that's similar, about equivalent to 5 micrograms of Cytomel. But for the most part, when I'm treating patients who are hypothyroid, I tell them, listen, figuring out the right medication for you is a bit like shoe shopping, meaning that sometimes we nail it with the first choice, and sometimes we don't. And we have to kind of futz around to figure out what's going to be the right fit for you in terms of your thyroid medication long-term. And so what I tend to start with is natural desiccated thyroid. I started 15 years ago, initially in my practice, with using more Armor. I treated a lot of patients who were part of this health maintenance organization, and I couldn't get Nature Thyroid for them. So at that time, I became more experienced with using Armor. I typically would start them with a half grain, and then gradually increase them depending on their thyroid function tests. I tend to repeat tests looking at thyroid function and tracking their symptoms with the symptom tracker about every 6 to 8 weeks. So 6 weeks is really the minimum to reach a new steady state in terms of thyroid function. Over the years, I started to use more Nature Thyroid. Both Armor and Nature Thyroid are pig origin. So as I mentioned, I often have patients who come to me and they're already on T4, and so I'll just continue that. This is levothyroxine, Synthroid, et cetera. Tirosint is another. I pretty rarely start patients on just T4 when they come to me de novo with hypothyroidism, and I'll get into the reasons for that in just a moment. So T3, I tend to use Cytomel here. Not everyone can tolerate it. It can be very activating for some of my patients, and so sometimes you end up compounding it. I have a number of friends that I've developed over the past 15 years who do compounding. And what they tell me is that compounding thyroid medication is harder than any other type of compounding that they do because the doses are so tiny. And so I just would urge you to be really cautious about using compounded T3. You can also compound a T3, T4 combination. Thyrolar is no longer used in the US, but you might hear about patients who have been treated with it in the past. And then, of course, we want to consider the broader systems biology, including the performing the cortisol unlock, helping patients with their cortisol levels. When I have a dried urine test and my patient has a really high cortisol load or high metabolized cortisol, I'm going to be addressing that along with their hypothyroid treatment. So let's talk about hypothyroidism and SIBO. The problem here, you hear a lot of integrative experts and so-called functional medicine experts talking about SIBO and hypothyroidism. When I look at the data, I actually find that it's not that robust. It's anecdotal. So we do know that hypothyroidism, at least in retrospective cohort studies, increases the risk of SIBO. It makes sense in terms of reduced motility. We know that when you look at a retrospective cohort for the development of SIBO, as indicated here in Breckman et al., 2017, the factors that seem to contribute the most to the development of SIBO are, number one, levothyroxine use, number two, impairment of intestinal clearance, so that's the decreased motility, and number three, immunosuppression. Now, in patients who have SIBO or have some other form of dysbiosis, we know that thyroid replacement alone is probably not going to resolve thyroid symptoms. And so we have to be addressing these root causes along with treating the hypothyroidism. So we want to be looking for the toxins. We want to be dealing with the stress. We want to be assessing gut function, looking at barrier function as an example, maybe performing some microbiome testing to see what sort of diversity they have. Do they have any pathogenic bacteria or other microbes? And as I keep repeating over and over again, we want to look for dysregulation of the hypothalamic pituitary adrenal thyroid gonadal gut axis. So I want to talk about, we talked about subclinical hypothyroidism. And there's debate about this, although I tend to treat it in patients who are trying to conceive or pregnant. But let's talk about another study that was published in the Journal of Clinical Endocrinology and Metabolism in 2013. And this was a very interesting study where they looked in a randomized trial at patients with hypothyroidism who were treated with just T4 versus the combination of T3 and T4. And what they found was that half the patients preferred T3 and T4. So I think that's important to understand because this is a bit of that shoe shopping analogy where we know that, when you look conventionally, about half of patients are going to be happy with T4. The other half are going to do better with a T3, T4 combination. But here's the real kicker. In this randomized trial, what they found was that desiccated T3, T4 was associated with modest weight loss compared to T4 alone. Now, for my patients who are over the age of 40 and they have hypothyroidism, they have thyropause, they're in perimenopause or menopause, this is an important deciding factor. And so we need some more randomized trials to confirm this, but this randomized trial was sufficient for me to use desiccated T3, T4 in combination. And I certainly found personally that it was very effective for me, and I found it to be very effective in the thousands of patients that I've treated. So that is the end of our talk, and I'm hoping we have a little bit of time to take your questions. I'm just going to look. I know I have questions. Here we go. Oh, 14 questions. How fantastic. Okay. What is the reason that endocrinologists don't like using Armour thyroid? Such a good question. So I believe that I have a lot of friends who are endocrinologists, and so I've asked them this question over and over again. And I believe that the main issue they have is that they just didn't use Armour thyroid when they went through their training. So they just aren't familiar with it. They're familiar with using T4 and in very rare cases, adding on some T3. I hope that that changes now that we have this randomized trial that was published in the best endocrine journal, JCEM. I hope that that starts to change minds. But I believe that, the classic treatment of hypothyroidism is going to be very slow to change. The other thing about Armour Thyroid is that it sounds gross. And I think there's sort of an ick factor. I'm speculating here, but I think there's an ick factor because endocrinologists think this idea of ground up pig thyroid that they're giving to their patients, where there may be some issues in terms of quality control and variability from pill to pill. I think that's another reason why they have some concerns. And so what I found with using Armour Thyroid and then switching to Nature Thyroid, and I'm not paid by either of these groups, what I found is that Nature Thyroid tends to give me a much better result. I tend to use the West Thyroid P, which is a very pure form. It's got a little MCT in it and no fillers. And that's what I tend to have the best results with. Would you share the different questionnaires you use for hypothyroidism, hormones, et cetera? Yes, I think this is a great idea. So I remembered this morning when I was coming on to the Zoom call that Will and Keith said, if you have any PDFs that could help our cohort, they're very interested in that. And I was realizing, I haven't sent a single PDF. So yes, let me share that with you. I'll also share with you kind of a small quiz that I made online, which is, I believe the URL, I haven't set it in several years, is thehormonecurebook.com/quiz. But let me try to find the ones that I use in my practice and send those over to you so that you can track them. Okay. Well, here's another person asking for the questionnaires. I can tell that's a big, important question. What genetic test did you use to check for the DIO2 SNPs? So I did this a while ago. I believe I used 23andMe. So I ran my 23andMe test, maybe 6 or 7 years ago, but you can browse the raw data and you can use those SNP IDs that I shared with you, RS, blah, 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 and you can search the raw data to see if you or your patients have a variant. I believe that that's what I did. I may have to correct that, but I believe that's the main way that I did. Oh, here's a great question. Abe, you always ask such good hormone questions. What is the function of reverse T3? So this is where I get to put my bioengineer hat on, because what I believe I believe the function of reverse T3 is to put the brakes on the production of the conversion of T4 to T3. So the classic function of it is that, if you have someone in the hospital, such as we have a pandemic right now, when you have someone in the hospital who's under extreme distress, say they're in the intensive care unit, reverse T3 tends to go up so that you can reduce the production of T3. You just don't need T3 to be helping you with keeping your hair on your head and with other metabolic functions of the thyroid. And so reverse T3 is kind of this backdoor, this way of breaking the process of converting T4 to T3. Okay. Let's see. What is your approach for treating low ferritin? So my approach for treating low ferritin is I do a full panel of iron studies so that I can understand how iron's being trafficked in the body. What I tend to do with low ferritin is I want to give them, of course, I want to give them iron, and I prefer the heme type. And so I tell my patients, even the vegans and the vegetarians, listen, if you really want to get your ferritin up, I'm agnostic about whether you eat meat or not, but eating grass-fed beef along with all the kale that you're eating and the dark green leafies is really going to help you replete your ferritin faster than if you just take a supplement. Now, there's a couple of supplements that I give to my patients just because it doesn't make a lot of sense for them to have, a hamburger every night wrapped in lettuce, grass-fed burger as an example. I encourage them to get a lot of different sources of wild meat and grass-fed beef so that they're not just having, one type. I suggest 2 to 3 times a week. And then in terms of supplements, there's a few that I like. There's a liquid form that I use for a lot of vegetarians, and the name is escaping me right now. Maybe one of you knows it. What's it called? Haven't used it for a while. And then there's another, I'll send you a list of some of the supplements that I tend to use. But I have a food first philosophy, and I think that's really important. Along with that, I think it's essential that people get sufficient vitamin C. And so I think it helps to improve the absorption of iron. And so I give that along with the iron. And one other point that I want to make about hair loss that I have in my book, let me just see if I can find it quickly here. I have it in so many different places. Let me see if I can find it quickly. Yeah. So one of the things I do with hair loss, this is a little clinical pearl. I have patients use their smartphone and take pictures of their hair. So like take pictures of their temples, take picture of how wide their part is, so that they have a sense of what their base case is before they start treatment. And then one really important issue with patients with thinning hair. This was a study that was done a while ago. In one study, 90% of women with thinning hair were deficient in iron and the amino acid lysine. Lysine helps transport iron, which is essential for many metabolic processes. Good sources of lysine are foods rich in protein, such as meat and poultry, eggs, and some fish, cod, sardines, as an example. And because grains contain small quantities of lysine, but legumes contain lots, meals that combine the two, such as Indian dal with rice, beans with rice and tortillas, falafel and hummus with pita bread are a good way to get complete protein in your diet and keep hair on your head. So that's page 252 of The Hormone Cure. Okay, looks like I'm a little bit past. If I could just answer one more question. I know you guys are eager to finish, but let me just answer one quick question. How do you address persistently elevated antibodies in patients? So this is such an important question because my goal with any of my patients with Hashimoto's or autoimmune thyroiditis is to normalize their autoimmune activity. And so what I tend to do is an elimination provocation diet. There's a lot of different ways to do this, but one that I found to be the most helpful is the one that's taught by the Institute for Functional Medicine. I hope I can mention them on this call, called the Renew Diet. And so I think that that's a really good system that has stood the test of time and multiple studies. And I found that that's been very helpful for my patients. And the idea is that the Renew Diet by IFM is very effective against autoimmune disease with gut problems. And also, there's one other category that I'm just blanking on. You know, one of the things you eliminate is sugar, which I think is an important factor here. I just was listening to a webinar on this. There's a third factor that it addresses, but I think the key here is that it's addressing an autoimmune condition and this issue of immune tolerance. Oh, the other thing is food intolerances, food allergies. And so what I find with a lot of my patients who have elevated antibodies is that once you start to treat their thyroid and you start to suppress this overzealous activity that's occurring in their thyroid, you put that together with an elimination diet such as Renew, you're removing things like gluten and grains and dairy, the most common food intolerances. I find that a number of my patients actually normalize in terms of their autoantibody production. Not everybody, but certainly I find that a lot of these patients can be dramatically decreased in terms of their autoimmune activity. So I think I'll stop there. I have 5 minutes after the top of the hour. And I just want to thank you so much for your engagement. I really love these questions, and I'll What I'll do is I'll get with Will and Keith and Kelly and send you my questionnaires so that you can use them. Oh, here's someone who said Floradex is the liquid vegetarian iron source. Is that the one you were thinking of? Yes. Thank you so much. This is, my last talk was on the female brain, and anomia, where you can't think of that word, is very common over the age of 40. So thank you for filling in that gap with Floradex. I appreciate it.
Thank you so much, Sara. It's been an absolute pleasure having you for this webinar. I learned a lot of new things about the thyroid that I'd never even heard of before. So really.
Oh, I'm so glad. Fantastic.
Thank you.
My pleasure.
We'll see you again soon.
Okay, sounds great. Bye, guys.
Bye-bye.
Thanks for coming.